What's important is do not use BMI for monitoring. BMI in kids is worthless because BMI changes over time. What you need to do is a BMI percentile for weight status, because an 18.5 BMI at age 6 is obese and at age 18 is underweight. Okay, so it changes your BMI how it should be over time. So that's why on the form, having a BMI is great, but you're steering them to think, oh, it's just a 23, it's not overweight. But for that kid, 23 might actually be close to obese. So I think what we need to do is give people the website how to calculate a BMI Z-score and a percentile. For long-term change of weight, you need to take normal growth into account. Kids should grow, they should gain weight. So here you should use the BMI Z-score to track it because it's not capped at 0 and 99. It's still not linear, but it's better than just weight gain. Kids, yes, of course they gain weight, but is it appropriate for their sex and age? Is it what you would expect for the growth curve? So it's very important that this is being followed and that we steer away from quasi-security and feeling everything is fine because the adult BMI ranges have not been hit, but for kids they are lower. That's often, we have a study where we have overweight kids that come in, and often the doctors say, well, looked a little chubby, but is that really overweight already? Yes, for that age, you should be really like this. And then the thresholds for diabetes and glucose are the same as in adults, but the thresholds for lipids are a little lower. And again, people should monitor that. And the question is whether this should be in a footnote mentioned in our guidelines, your guidelines for wherever antipsychotics are assessed in order to really make sure people monitor the right thing. And then maybe just for your edification, because we just published it, in terms of what gives you the most weight loss, it's basically a wash. Whether you use switching, whether you use cardiometabolic or healthy lifestyle instruction, or metformin or topiramate, all based almost exclusively on adults, but it's about 3 kilograms in 3 months. Yeah? That's not great because kids gain so much more over the time, but whether you use it concurrently with starting the antipsychotic and prevention 3 kilograms, or you give it in adults, that is, after weight gain has occurred, it's again 3 kilograms. But you can see with that 3 kilogram change, significant decrease compared to the control condition in cholesterol, 21 milligrams per deciliter, LDL, 22 milligrams, and here, triglycerides, 62 milligrams per deciliter. That's enormous. So even a smaller weight change can actually confer some significant benefits in terms of the metabolic side effects. But again, as we've discussed before, it's hard to get people into that. And whether you should continue, most likely yes, because after when we stop the intervention, then people seem to start gaining weight again. For BMI, there was no difference anymore. For weight, in another couple of studies, there was still a difference. So most likely booster sessions will be needed. Adding a stimulant to an antipsychotic does not reduce weight gain, it's overridden. But topiramate and metformin, about 3 kilogram weight loss. Nobody has studied both together. My prediction is it will boost the weight loss because they have different mechanisms. Okay, so prolactin increases with risperidone, paliperidone, and haloperidol the most. Intermediate in kids are ziprasidone and olanzapine. They cause elevations. In adults they don't, but in kids they do. The only neutral agents are quetiapine and clozapine, and aripiprazole actually reduces prolactin levels. There are now several studies where even adding aripiprazole to ongoing haloperidol or risperidone treatment will reduce the prolactin levels. There was a study last month in the American Journal of Psychiatry that adding metformin doesn't only reduce weight but can also reduce prolactin levels and restore amenorrhea. The problem with prolactin levels is we don't know what they mean at a certain level because there are some kids that have sexual side effects or reproductive side effects at normal levels, high normal, and others have sky-high prolactin levels and don't seem to have side effects. So we proposed and still propose that you shouldn't really look because they are higher unless you have clinical side effects. That would be gynecomastia, clearly galactorrhea. You need to stop because that means you have hypogonadism, and that's what you're worried about. You're not worried about the prolactin level. You're worried about that prolactin shuts down gonadotropin-releasing hormone, which shuts down then sex hormone production. So if in doubt, I think what you should do, draw sex hormones. And if they are normal, I think you can go on. But if they are really abnormally low for age, then you are worried. Now we can get into the problem with osteoporosis. Adolescence is the prime time for bone mineralization for the rest of your life. So if you don't get enough minerals into the bone, that will hurt you later on. Interestingly, in kids, prepubertal kids where sex hormones are not there or very small levels, the bone mineralization seems to be somewhat uncoupled from sex hormones. So we don't know in prepubertal kids how much hyperprolactinemia is bad for bone. Nobody has looked at that long term. And we don't know whether high prolactin levels delay or upset the pubertal development. Do they have delayed puberty? The thing is that often kids that have high prolactin levels on antipsychotics also are obese, and obesity then increases or preempts puberty because you have more fat tissue that can convert precursors into sex hormones. So maybe that then counters it, but again, no data on that.